Good morning. Thank you, everybody, for coming, and Mona and Jen for having me as part of the panel. So I'm going to talk about the new kid on the block, and I believe this is non-CME, right? So we can. Okay, so we're going to talk about ELICOR, which is tissue microcoring, and then some of the stuff that's in the future. Oh, there we go. Those are my disclosures. So I think the previous speakers kind of set it up nicely, right? And this is kind of a question that I've asked myself many times, right? What tool do I reach for if the patient comes into my office complaining about excess skin? And I'm a dermatologist, I'm not a plastic surgeon. So oftentimes they're coming in because they don't want a surgical intervention for whatever reason, even if they're a candidate, right? And so the answer for this kind of depends on what time it is. But honestly, this has always been a conversation that I've never been that excited about because it's something patients are really, really interested in, which is great, but it's always classically been very hard to deliver good results for these patients. And I don't know if I have the answer even still, but you know, this is the thing I'm kind of most excited about for tissue laxity, right? And so you know, you want to define, as the previous speakers did, tissue laxity, right? And there's a whole range of it, from people needing surgery to folks that are in their late 20s, early 30s, where they really don't even need anything. They're kind of looking to prejuvenate or just prevent aging. And there's this kind of graveyard of devices, as Jen was saying, that have tried to fill this gap. And that's where I think ELICOR really fits in. So this is, you know, what is ELICOR? It's not a laser. It's actually basically a mechanical process where we're cutting out cylinders of tissue that are full thickness, epidermis and dermis, and a little bit of subcutaneous fat. Think of it, as a dermatologist, we call them punch biopsies. Think of this as a motorized punch biopsy where we're cutting out cylinders of skin. Now, the trick to this is that we've figured out that there's a certain size, and if we stay below that size of tissue that's removed, the body will heal up in a scarless kind of fashion, right? And so the size of the core is about 430 microns. And there's been nice studies showing that when you stay kind of under 500 microns, you can get tissue to heal up and close without any scarring, although scarring is a risk of this procedure. And so basically you can take out thousands of cores. So instead of a plastic surgeon cutting out, you know, a piece of skin on each side, you can take out thousands of cores of tissue with this. There's no heat or thermal energy. And for that mechanism of action, that's exactly why this procedure, I think, works fairly well. And it does entail a little bit of downtime, but comparing it to something like a fractional CO2, which when that came out, we had a lot of high hopes for skin tightening with that. I find that actually has a lot more downtime than you know, ELICOR or tissue microcoring. So what are the different modalities? We've touched on them in the prior talks, but basically this is mechanical tissue coring. So we're just removing a cylinder of skin. There's no heat or thermal energy, right? And so that's the difference between this and fractional CO2. Where with fractional CO2, you also remove a column of skin. It may not be full thickness, so that's one difference. But the second difference is that you deposit a thermal kind of handcuff around the area that's been ablated, right? And so now the thought process is maybe that handcuff is actually preventing those holes from kind of closing up and getting any sort of meaningful skin tightening. A lot of patients will also say, well, how is this different than microneedling? Because it looks very similar. Microneedling is also mechanical, but it's just a needle going in and out. There's no removal of tissue, right? And then we have the RF and ultrasound RF microneedling, where you can actually deposit heat and energy in the skin, or ultrasound, or just pure monopolar RF or thermage. And those are all great modalities, much less downtime, but really they skew towards the folks that really don't have much in the way of skin laxity or significant aging. So this was developed by doctors Rox Anderson and Jay Austin. Everybody in here should know who Dr. Anderson is. He's developed a lot of the technologies we talk about. And then Jay Austin is the chief of plastic surgery at Mass General Hospital. And this was a concept they thought of over 10 years ago. So it's taken a long time for this come to market. So let's walk through just a little bit of the science, right? So how did they settle on this 430 micron size? Well, they looked at basically removing cores of tissue ranging from 200 microns all the way up to 2 millimeters in size. And they found that the sweet spot was when you were below 500 microns. So you want the biggest size that reliably doesn't leave any scarring. And that's the paper if you want to pull it and read it, which I encourage you to do. So this underwent, like every device, some clinical studies, basically showing safety and efficacy. I'm going to just skip this in the interest of time. But here's some histology. I do want to pause on this because we talked about scarring, right? And we didn't see any clinical evidence of scarring, but we also don't see any microscopic evidence of scarring in the studies as well. So you can look at 90 days out. There's no kind of increased evidence of scarring with this procedure. This is optical coherence tomography imaging, and this was done by Jill Weibel. And this also kind of shows the difference between fractional CO2 and tissue microcoring. So you can see with the tissue microcoring, you can see the channels that are open, and you can see them start to close as soon as 10 minutes after the procedure, right? And that's because you don't have that heat around it that produces a bigger wound healing response. Whereas with fractional CO2 laser, these channels stay open a lot longer, right? And so that's, aside from the size of the core, that's another fundamental difference. And I see this clinically in my practice now that I've been using this close to 2 years. So like this is a procedure. This is not something where someone's going to come into your office and you're going to just say, all right, we're going to do this today, right? You want to make sure you prep them and make sure they have the right expectations. So I set aside an hour for this. I use not just topical, I use local anesthetic. You really have to do this, I think, to make patients comfortable. You can remove, about 5 to 8% of the skin in each procedure. And the post-procedure care is actually pretty simple. Right now, it's just Aquaphor and gentle cleanser. And I just have them do it twice a day. So it's a lot simpler than resurfacing with a fractional CO2 laser. This is just the anesthesia protocol I use. I'm going to just skip this in the interest of time. I'm happy to chat with anybody if you want to talk about this more. This is the user interface of the device. You can see you can control the depth and you can control the density. Obviously, the higher the density, the more aggressive the procedure is going to be, and the more risk for side effects and downtime. You can see that little image there. We talk about with lasers clinical endpoints that you're looking for. There's not a endpoint other than you're looking for tissue coring, right? So you want to fire the device and you want to see these tissue cores. If you're not getting these tissue cores, you're not getting the proper response. So that's what you really want to look for. This is one of the first patients I treated. So when this first came out, we were kind of from the clinical studies thinking that it would be around a 3-day downtime. I don't think that's true. I think the downtime is probably more closer to about a week. But this was a patient diary of one of my earliest patients that did this, and she did fit the 2 to 3 days of downtime. But I tell them, plan on a week of downtime. There's often bruising and swelling with this also, so Jen's 100% right. This is definitely a procedure you need to prep them for and let them know ahead of time. I'm going to just skip this also, but one of my favorite things to use this for are those kind of lines on the medial cheeks, like Jen was. Yeah, this is a really hard thing to treat with filler, and it's really hard to treat with other modalities. Even fractional CO2 leads to unsatisfactory results. So I'm going to just skip over this. I'm going to just share a couple of my clinical images. So this is a patient after one treatment. And Jen, I love that analogy you used, the tablecloth. Because when I first started seeing these patients, I said, wow, it almost looks like these patients are getting filler, right? And with filler, we're injecting volume so that we plump up the underlying structures to plump the skin. And think about this. This is kind of like the yin to that yang. We're taking out excess skin so it sits better on the underlying bony structure. So it's no surprise that we almost see these filler-like effects. This is probably my best result. This was a patient that she's beautiful. She's always been disappointed with her lower face. She does, she's a cosmetically savvy patient, and we've tried everything from microfocused ultrasound to microneedling RF, and it was the ELICOR that finally helped her get to where she wanted to be. And this is what I think actually the ideal patient is. It's not the person that's coming in that's pushing their cheeks up that says, hey, I want this doctor, because I think they're probably too far gone for this. But the patients that are kind of in their mid to late 40s, 50s, and early 60s, those are the ones that are going to do the best with this procedure. And it's not a one and done. I always tell them plan on a series of treatments. This is one from Matt Avram, a colleague of mine, and this is one of the things I love using ELICOR for. Here's a couple of other results. Certainly you can achieve this with some other modalities as well. Here's another one from a plastic surgeon in Texas. So how does, ELICOR is not a be-all, end-all and a solution and the only device I need, but it fills a gap in my practice. I think it's pretty straightforward to use. It is a technique-dependent thing. You do have to set time aside for this. You cannot rush through it. I do not delegate this, and I think that's key. I think not only does it address laxity, but it also addresses these lines. Around the mouth, this is another area where it's kind of a home run. Fractional CO2 has been a nice modality to use, but it often comes with a lot more downtime than ELICOR. It is safe. It is possible to get scarring, and this is definitely where technique matters, right? Because think about it. With lasers, we're taught to overlap, but if you overlap with this and you punch a hole where there's another hole, now the size of your hole is going to be greater than 430 microns, and that's where you can get into trouble and have scarring. This is a new technology and a new modality, so I think this is just the tip of the iceberg. With the lower face, this is people are already using it off body. I'm a little more conservative. I think we need the data before we start, pushing it there. But remember, this is a way to remove tissue, right? So can we do tattoo removal with it? Can we treat scars? These are all questions that I think we're gonna be discussing in future meetings. And then I want to close in terms of future directions. So I think ELICOR is the new kid on the block. But there's always, the beautiful thing about this field is there's always innovations and new things that are coming out. So there's this new technology. This was also developed by Dr. Rox Anderson, Dieter Manstein, and Henry Chan. And this company is called Aveva. And basically, it's a new or novel way of delivering laser energy, right? So traditionally, lasers are collimated. And when the laser beam goes through the skin, whatever your target is, pigment, blood, right? The energy at the top of the skin or at the epidermis is the greatest, and we lose laser photons due to scattering and other effects. By the time we get down to our target, we have less of those laser energy beams, right? So sometimes we have to turn up the energy, or the epidermal melanin absorbs some of the chromophore, and we want to avoid that. They've kind of turned the needle on the head, and what they've done is they've delivered the laser in energy in a conical fashion. So the energy is more broad at the top, and it concentrates at a focal point, which you can control with the device where you want it, where your target is. So that's where the energy is the most intense and the strongest. So when it's more diffuse at the top, when it's delivered, it's less likely to be absorbed by that epidermal melanin. It's also less painful, and it also comes with the potential for less downtime and recovery. So all of those are kind of win-win-wins. So this technology was recently FDA cleared. It's just coming out on the market, so there's a lot we have to learn in terms of protocols and optimizing treatments, but I'm really, really excited about this. I'm going to just share one of the clinical images that I think was really exciting. You might look at this and say, oh, what's so great about this? But when you animate this, and this is really good standardized photography, look at that brow lift. Yeah, I have it on repeat, right? So this is another one of those modalities Jen was talking about, right? The holy grail is something that tightens and has minimal downtime, right? And that's been very, very hard to do. But this is where I'm really, really excited for this technology, because one of the other limiting things has always been treating skin of color with lasers and doing it safely. And this is something that we can use in all different skin types. And so it kind of democratizes some of the anti-aging technologies that we have. So with that, thank you so much for your time and attention.